I want to walk you through a peer-reviewed, published case study, a real patient with real lab results, and a sequence of events that I think every clinician working with complex patients needs to understand. Not because the outcome was dramatic, though it was, but because of what the testing sequence reveals about how we think about vector-borne disease detection. This is a case study published in Frontiers in Psychiatry in 2023, authored by Dr. Amy Offit and Dr. Ed Breitschwert. The patient is a teenage boy. He came in with a diagnosis of autism spectrum disorder, ADHD, PANS, and autoimmune encephalopathy. He had been ill in one form or another for most of his life. Multiple providers, multiple workups, extensive history of treatment attempts. He had been tested for tick-borne infections before. Bartonella serology from two separate laboratories, negative. Babesia fish, negative. Lyme serology interpreted as overall negative despite some individual elevated markers. Years of testing, nothing confirmed. At age 17, he and his mother enrolled in a research study using high sensitivity enrichment blood culture combined with droplet digital PCR. This protocol was designed specifically for low abundance, intermittently circulating pathogens. They ran IFA serology again first, both the patient and his mother. Seronegative across all 5 Bartonella species tested. They ran standard qPCR, Bartonella negative, Babesia negative, Borrelia negative. They ran droplet digital PCR on enrichment blood cultures. The patient, Bartonella quintana, confirmed by DNA sequencing. His mother, Bartonella cholerae, confirmed by DNA sequencing. Same patients, same blood draws, serology negative, standard PCR negative, droplet digital PCR on enrichment blood culture, confirmed positive. The authors are meticulous here, and so should we be as well. This is a research protocol with 24 independent DNA extractions per person. It is not a standard clinical panel, but what it demonstrates is the principle that matters for your practice. Bartonella circulates at extremely low levels. It cycles in and out of the bloodstream. It can suppress immune response that serology is designed to measure. When the organism is present at concentrations too low for standard methods to detect, a negative result is not a ruled out result. It is not found with this tool result. The gap between those two things is where patients like this one spend years. After antimicrobial treatments targeted at the confirmed infection, this patient moved from a long-term special education setting with accommodations to grade-level academic standing without accommodations, and he was accepted into college. The authors concluded that incorporating diagnostic modalities that detect pathogen antigens, or DNA directly, would allow for an increased support for a causative role in neuropsychiatric presentations like this one. The infection was there. The serology did not find it. Direct detection did.